عليكم ورحمة الله وبركاته. معكم الدكتور إيهاب بكر عبد الرحمن إيهاب طراوة consultant for healthcare medicine at Sowa University Hospital و Associate Professor of Medicine, Faculty of Medicine, University of Khartoum. In this session, we're going to talk about rapid response strategy and ICU without walls. This is a continuation of the previous lecture, which is about assessment. So we spoke about assessing an acutely ill patient, and now we would like to organize our assessment in a system-based approach. The objectives of this session, we would like to recognize an acutely ill patient as soon as possible. We would like to execute system-based assessment program. يعني حاجة يطبقوها كل الناس اللي في المستشفى أطباء وتمريض to design resource sensitive response. This is a chart of a regular floor patient. You see this patient, his temperature is fluctuating and he's becoming febrile. At the same time, his heart rate is moving and he's becoming intensely tachycardic. And his blood pressure is dropping here. And it reached a moment that I guess in this moment here, the guy arrested. This deterioration is happening over time. It's going through hours. It is well recognized that most arrests are predictable. Deterioration prior, 50 to 80% of cardiac arrest, patient is deteriorating over time. Hypoxia and hypotension are common. There is always delay in recognition, there is delay in response. So, natural history of many illness, usually you get prolonged hypoxia and shock. So, cells are not getting oxygen, are not well perfused, and this will stimulate inflammatory mediator, and this will lead to multi-organ dysfunction. Irrespective of etiology, whenever there is significant hypoxia or hypoperfusion, then the body releases a lot of mediator and this leads to dysfunction. This looks like a match lighting the fuse, which activates the blasting cap, which will set the explosion. Match lighting the fuse, which activates the blasting cap, and this will set the explosion. So the match is the hypoxia and shock, hypoperfusion, so lack of oxygen at the level of shock. So this will trigger inflammatory response. At the beginning, when we recognize it, we can, and if we do the appropriate response, we can avoid deterioration. So then this will lead to stimulation of inflammatory mediator, and consequently, this will lead to recruitment, activation of macrophage and other inflammatory mediator, and at the end we get multi-organ dysfunction. And that will be the explosion. So, should we wait till our patient develop multi-organ dysfunction, which mean when they get arrested and they call code blue team? At that time, this look like the fire. It look like the fire here. So, or we should respond when we get a slight deterioration, when there is a small spark. At this moment, we can extinguish this fire by IV fluid when it is hypoperfusion and hypotension, or when it with oxygen when it is due to poor oxygenation. So this is why the most important intervention for deteriorating patient, acutely ill patient, emergency room patient, critically ill patient is to maintain the airway and breathing. So make sure airway is patent, make sure he's breathing, make sure it's effective breathing. And then you go to circulation and make sure it is well perfused. So system monitoring revealed that sick and at-risk patient in ER and ICU usually receive effective resuscitation. Why not we implement the same concept in all hospitalized patients? The difference is not because they are in ER, it's not because they are in ICU, it is because of application of ABCD approach. It is about make sure airway is patent, make sure he's breathing effectively, make sure circulation is good, and then you do the assess disability, and then you expose your patient. So if we can use this all the time, then we can save life. But we need to respond. The earlier we do it, the better the outcome. As Jackson Brown mentioned, nothing is more expensive than missed opportunity. Nothing is more expensive than missed opportunity. Missed opportunity, majority of in-hospital cardiac arrest were potentially avoidable on those receiving inadequate treatment. Inadequate because of delayed recognition, because of delayed response. 70% of patients show evidence of respiratory deterioration within 8 hours of arrest. Many times physicians were notified and they didn't do the appropriate job. If we recognize this patient early, some hospital applied what we call rapid response team. Is a team of doctor and nurses, team of medical care provider who recognize deterioration as early as possible. And when they come and when they see the patient early and when they implement the intervention early and effectively, they can reduce 50% in non-ICU cardiac arrest. I think it's worth to invest a lot of money in training people on how to avoid arrest and how to recognize patient early. And also it lead to reduction in post-operative emergency ICU transfer. When we have this rapid response strategy, it cut down from 58 to 37. It can reduce arrest prior ICU transfer. It used to be 30. When hospital applied the rapid response team, it became 4. So this is a very good and very effective intervention. And this diagram showing the reduction in code blue outside the ICU when they implement the rapid response team, it led to significant drop in the arrest, as you see here. So, what is the role of the rapid response system or rapid response strategy or rapid response team? I prefer the word strategy because it gives us a room for designing our response based on the available resources. So the team need to assess, need to stabilize, need to assist with communication between the floor team, between the resuscitation team, between the ICU or high dependency area team. And they need to educate the staff. So this is what we call outreach teams. They educate them and they train them about how to recognize the patient early, and they assist with transfer if needed. So when we implement this rapid response, we need to detect, so early detection of deteriorating patient. We need to design our response. How soon should we assess, and the competency of the person assessing the patient. So early recognition, timeline response, and competence. In order to make the chart of early warning score, we need to check the 6 physiological parameters. We need to measure the heart rate, respiratory rate, blood pressure. We are more interested in systolic blood pressure. We need to measure the temperature, and we need to check the level of consciousness. The oxygen saturation is important, but if you cannot measure it, I know in many of the rural hospitals, in some of the small hospitals, they cannot measure saturation. So they can use what we call modified, the same 6 parameters. So when we use 5 of them without saturation, this we call it modified early warning score. Interestingly, whenever the patient is hypoxic, he is always tachypnea and tachycardia. So whenever the patient gets a score of 6, usually this is alarming. It alerts us to do some interventions. To utilize early warning score first, we need to measure and record the 6 physiological parameter, and we need to create score. And the score increases and decreases depend on the physiological parameter. But one of important things to note is that if the patient is getting supplemental oxygen, he will get 2 in addition to his basic score. After we measure the vital sign and we record them in patient record, and we mentioned that we add 2 for supplemental oxygen. So first, we like to use the early warning score record to define and write the data in the sheet, and then we calculate the score. And after we calculate the score, we need to decide if escalation is needed. If the score is less than 4, the patient is stable. He can be monitored as usual every 6 hours, every 8 hours according to the unit protocol. But if the score is up, then patient need immediate assessment by a nurse or by house officer, by a medical officer. If the score is very high, then for example, if the score is 8 or 9, this indicates an urgent response. Someone should come quickly and assess this patient. And if the score is very high, we need to determine the competency, because if someone with a score of 15 probably has some airway issues, and we need someone who is competent in airway management. Probably he might need intubation or advanced airway management. Depend on the score, it will determine the frequency. So if the score, for example, is just 5 or 6, then the patient is hypotensive, tachycardic. You give him fluid and you check again in 1 hour. But if he's severely hypotensive and the score is 9, and he's hypotensive, tachycardic, tachypneic, so you do immediate fluid resuscitation. You need to check again in 10 or 15 minutes. You might need to stay beside this patient. You might need to bring a monitor beside the patient. And also you need to determine if you want to implement therapeutic measure and reassess, or you need to take this patient to another level of care, for example, high dependency unit or emergency or ICU. You can see here in the early warning score, if the patient is stable, his score will be around 0. If his respiratory rate is 16, he's getting 0. Saturation more than 96, he's getting 0. When he's in room air, he's not getting supplemental oxygen, then his score is still 0. When the temperature, the systolic blood pressure, the heart rate, and the level of consciousness all are stable, then the total score is 0. So the total score of this patient less than 4, this patient can be monitored regularly. You can do the vital sign every 6 or 8 hours according to the unit protocol. In this scenario, this guy, his respiratory rate is 18, so he's getting 0. Saturation is 98, and he's getting another 0. He's in room air, so he's getting a third 0. His temperature is normal. His systolic blood pressure is normal. His heart rate is normal. He's alert awake oriented, so the total score is 0. This patient is stable, can be monitored in the regular floor, and they do the vital as usual. In this scenario, the guy is a little bit tachycardic and tachypneic. So his respiratory rate 24, he's getting 2. His saturation 98, getting 0 in room air, another 0. His temperature getting 0 for the temperature. Systolic blood pressure 110, another, sorry, his systolic blood pressure is 100. So he's getting, his systolic blood pressure is 100, he's getting 2. And his heart rate is 110, he's getting 2. So, and his alert awake oriented 0. So you can see he's getting 2 here in the respiratory rate. He's getting 2 in the hypotension, and he's getting 2 for the tachycardia. So the overall score is, so he's getting 1 for the tachycardia. So 2 plus 2 plus 1, the total score is 5. This guy is a little bit hypotensive, little bit tachycardic, little bit tachypneic. So if it is fluid deficit, if you give him IV fluid, probably his systolic blood pressure improves, the score will get down, his heart rate might go down also. So, and you need to implement measure, you need to reassess him in 1 hour, and if he improves, you keep him in the same location, but with frequent check. But if he doesn't improve, you might decide to see if it's appropriate to take him to high dependency unit. In this scenario, this patient is tachypnic is getting 3 for his respiratory rate. His saturation is not reading, so he will get less than 90. He's get another 3. And when you get such a patient whose saturation is not reading, then you're going to put him in non-rebreathing mask. So he's in supplemental oxygen, he's get another 2. His temperature will take 1. His systolic blood pressure is 70, he's getting 3. His heart rate is 144, he's getting 3. And he's confused, so he's getting another 3. So this patient score is very high. You see 3 here, 3 here, 3 here, 3 here, 3 here. This is 5 3 is 15 plus 2, 17, and 1 here is total of 18. This guy is very sick. He needs immediate attention. And since the consciousness is impaired, he is very hypotensive, very tachycardic, very tachypnic. Probably he needs level of ICU level of care. The one who attends this patient should be competent in airway management. Probably he needs intubation. When people come and see him, they need to make sure his airway is patent, make sure he's breathing okay, make sure he get enough oxygen and effective ventilation, and he need resuscitation for his circulation. And this guy might need to be taken to ICU quickly, and probably he needs intubation before they take him there. As Martin Luther King Jr. mentioned, if you fail to plan, then you plan to fail. Patients in the floor, in hospital, in the ward are very sick. They deteriorate over time. So we know this fact. We know they are deteriorating, and we have this information in our chart. So we need to record this information. We need to respond appropriately. We need to measure the early warning score, and we need to respond whenever the score is more than 4. And if the score is very high, immediate attention is needed by someone who's competent. So take home, early warning score is a good tool for monitoring deteriorating patient. Structured approach and time-sensitive response can be triggered by early warning score. Enhancing staff training competency is important for implementation of effective response.